Good evening and a very warm welcome to tonight's webinar, Best Practice Exercise and Physiotherapy Prescription in Multiple Sclerosis. We've got two fabulous presenters tonight, Andrea Salmon and Gilly Davy. And I'm your facilitator, Nicola Graham, along with Associate Professor of Physiotherapy, Paige Hooper. So this webinar this evening is a collaboration with APA and MS, and we want to give you all a really heartfelt thank you for coming along this evening, especially those of you who may have had a busy day already. And thanks for taking the time to upskill in this really important area. Hope you've got a cuppa or a glass of wine and you can sit back and really enjoy all the content that we've got for you this evening and all the information that's really going to help and inform your clinical practice. We've got lots and lots of people online tonight, some international, and literally hundreds of people around Australia joining us, so really fantastic result. I'm going to hand over to Paige, who will now welcome you on behalf of APA.
Good evening, everybody. Thanks for having me tonight. Just on behalf of the APA, I'd like to welcome all of our members and non-members to the webinar tonight. It's a really important practice area and we're just so excited to have some education delivered in this forum tonight. So thank you, Gilly and Andrea, for the presentation ahead of time. And as usual, the content will be available afterwards on the website.
We like to start all of our programs with an acknowledgement to country. So in the spirit of reconciliation, both APA and MS Limited acknowledge the traditional custodians of country throughout Australia and their connections to land, sea and community. We pay our respects to their elders past and present and extend that respect to all Aboriginal and Torres Strait Islander peoples today. So it's with great pleasure that I introduce our two fabulous presenters today. Andrea Salmon is an occupational therapist and learning and development coordinator here at Multiple Sclerosis. She's got a Bachelor of Applied Science in Occupational Therapy, a Diploma of Leadership Management and qualifications in Training and Assessment. And she has been at MS for over 19 years now. So Andrea's knowledge of MS is extensive. And then our main presenter tonight is Gilly Davy, and Gilly is a neurophysiotherapist and founder and director of MS Get a Head Start. Gilly is a consulting neurological physiotherapist and a clinical director of Connect Neurophysiotherapy, and Gilly is presenting from New Zealand. So just a little bit about the MS Get a Head Start program. It's Gilly's brainchild. It's been operational since 2012. Gilly researched, trialled and developed the program, pulling together a wide range of evidence-based approaches and combining a unique approach of interval training, exercise, education, and of course, ultimately of self-management. And Gilly graduated in the UK in 2004. She was awarded the Australian Physiotherapy Association Ipsen Special Commendation for Achievement in Neurological Physiotherapy in 2015. And in 2016, she was then awarded an honorary clinical fellowship for the Australian Catholic University. So there are fabulous presenters tonight. And I'm now going to hand over to Andrea, and so that Andrea can start the presentation tonight with an introduction to some of the main features of MS.
Thanks, Nicola. I feel a bit of a fraud, really, because I'm only here for the very start. You're all here to see Gilly. I get that, no problem at all. So we do, I add my thanks too. Thanks for joining us tonight as we take a deep dive into a better understanding of exercise and physio interventions for people living with MS. We just want to start by recapping that MS is the most common progressive neurological condition of younger Australians. MS is a disease of the central nervous system where the myelin sheath becomes inflamed. Signals along the nerve pathways become interrupted temporarily, or it can be permanently if the nerve fibre or the axon is damaged. We're talking about a disease with many and varied symptoms many of which are invisible. A disease where there's complex interplay between symptoms and where the impact can be minimal to devastating, depending on the symptom mix and the individual's circumstances. We know treatments are available for disease progression and relapse management, but treatment is more than medication for the disease, as it's so important to manage the symptoms and to prevent disability. So we thank you all for being part of tonight's program, and we specifically thank Gilly for her work in this area as well. At MS, we want our clients to have the best possible experience of care and support, so we have a range of training available for you all. In our health professional webinar library, you'll find recordings about cognitive screening, fatigue management, and other topics that will assist you to feel confident and enabled to bring your physiotherapy expertise to the person living with MS for best outcomes. You might see your clients with MS as having some of these characteristics. So it's really important to know more than the treatment approaches, to also have an understanding of the individual you're working with. It's also important to recognise how cognitive symptoms or even the fatigue experienced can impact how the person functions. To be aware that heat and stress both have an effect on frustration tolerance, organisational and planning skills, attention and concentration, the ability to complete tasks, or to participate fully in therapy programs. So there's a lot more to it. And finally, before I pass you over to Gilly, a word about the expanded disability status scale. This is a method of quantifying disability in MS and monitoring changes in the level of disability over time. It's used widely in clinical trials and in the assessment of people living with MS. The EDSS scale ranges from 0 to 10, and it's based on measures of impairment in 8 functional systems. So Gilly will be referring during her presentation to case studies of clients, one at the EDSS level of 2 and one at level 7 for comparison as part of her presentation. You are a vital part of the bigger picture of a person living well with MS. And we want you to know that we're here to support you as well. So thanks for being part of the program, and I will click a couple of buttons to allow Gilly to be the presenter.
Lovely. Well, thank you ever so much for the invitation. It's always an absolute pleasure to come and talk about a topic I'm very passionate about. The hardest thing for me is always trying to keep it in the time limit, so I will do my best. So huge thank you to MS for the invitation, and obviously for APA for inviting and supporting and getting the great publicity to have such a great turnout. So thank you ever so much, everyone. So as a lovely introduction by Nick already, I am a clinical neurophysio, and I think it's always a good thing to start with to let you guys know that I am hands-on. You know, I treat 100% caseload back to back, and this is my fabulous team. We are here based in Auckland, and as Nick said, I am the founder of MS Get a Head Start. Based in beautiful New Zealand. Auckland has been in lockdown for the last 3 months, similar to lots of you around your country as well, but at least this is what's on my doorstep, so it is not too bad a place to be locked down. So one of the reasons I'm really passionate about talking about MS is this slide that I opened at one of the MS Australia research days, a couple of 2019 now, is the really shocking fact that 80% of individuals with MS are below the recommended activity, or actually really completely inactive. And what is even more shocking about this is that this hasn't changed for the last 25 years, even though we have had substantial evidence proving that MS exercise can be really influential on MS. So this is kind of where I think that as therapists, bring some pretty loud bells that we need to obviously be changing kind of how we're approaching this. But before I get into anything more, I'm just going to ask Nick to just run 2 polls, just so you can tell me a little bit more about yourself. So I've got a bit more idea about who in the audience is there, and then we'll do a second poll after that one, which is what involvement do you currently have in MS rehab? So it just means that I can have a little bit of better idea of what's going on with you guys.
So, Gilly, we've had about 70% of people have already voted, and so we'll just give people a couple more moments. It's anonymous, so please feel free to vote away. And nearly everybody has voted. I'll close the poll in a moment and we'll share those results. So here we go. Just wait for a couple more people. That's lovely, guys. Okay, I'm closing that poll and just sharing those results. So we've got 27% of people in private practice, 33% in community practice, 34% in public or hospital, 5% are students, and 2% are research or other.
Fabulous, thank you. And then the second poll, what involvement do you currently have with MS rehab?
Okay, so just launching that poll for people to vote. It's fantastic. People are just voting now.
Just really making sure that you guys are all there watching, you know, you're not turned it on.
Right. That's right. Okay, that's great. Most people have voted, so I'll just give a couple more moments and then we'll close that poll. Okay, so we'll just close that poll now. Thank you everybody for voting. I'll just share those results with you. So 16% of people have no involvement, 16% early diagnosed and minimally impaired. Most people at 49% moderately impaired, and 19% are working with people who are significantly impaired. So I'll hide that and it's back over to your screen, Gilly.
Excellent. Okay, so today's journey, we're going to have a bit of a blast through the latest evidence behind MS and exercise. There's a lot of evidence coming through, so I'm not going to try and stay too stuck on it, but I'll get through the main parts. And briefly go through the assessing and testing in MS, which obviously you guys are obviously as therapists have that well covered. Looking at some of the exercise prescription, there's been some new guidelines published, which is some really good reference to go to. But my aim of today is to make this quite clinically applicable. So we're going to go through quite a bit about the clinical application of common MS, you know, treatable areas, foot drop, knee hyperextension, hand weakness, and then just rounding it all off with looking at 2 different individuals with MS at that 2 different kind of ends of the EDSS spectrum, just so you can kind of see how I put a little bit of it into practice.
Gilly, I'm just flagging, we can't see your screen at the moment, so I don't know if there's anything you need to press to share your screen on the control panel, or if I might take it back to me and back to you to see if that, there we go, that's great. And if you go into presentation mode, that's lovely. We can see it all now, perfect, thank you.
Beautiful. Oh, there's that, hang on. How are we now? Okay, I'm
yep,
presuming
that's perfect. Thanks, Gilly. Okay. All good.
So before we kind of dive into much, I just want you to really firstly have a little think about MS and about the individual that walks in to see you in your clinic, and what is actually a primary impairment. You know, what is actually only due to the disease pathology that's being presented compared to that secondary impairment, because we know of the central nervous system degeneration, that the process results in this vicious cycle of reduced mobility, decreased physical activity. So you've really got to question yourself, you know, when you meet someone, what is the pathological impairment here, and what is it potentially a secondary consequence? And the reason why it's important to think like this, because it just suddenly makes a lot more people have an element that is treatable and that influence of improvement. And I've been working in neuro for close to 20 years, and with MS, you know, hundreds of people with MS, and, you know, there generally is always something that can be treated, which I think is really important, because for a long time MS was very much looked like it's neurodegenerative, there's not much we can do apart from compensatory and conservative. So, you know, before we get going, I just really want you to kind of think about, you know, what is purely due to the demyelination impairment compared to what can just be that secondary inactivity. So unfortunately, when we think about that why behind why are 80% of individuals with MS less active than what they should be, is that they've got some pretty big barriers, but there's also a huge amount of fear. Okay, so there's been some investigations into the barriers around physical activity and exercise, and people really feel like they're losing this kind of constant battle. It's a cycling of deconditioning and symptom worsening. And many people, you know, many individuals with MS, when asked about this, were actually concerned that exercise would aggravate their MS symptoms or even trigger a relapse. And we now know from the evidence that it's really clear that exercise does not cause relapses. If anything, it actually reduces that relapse rate, but there's still that perceived fear around it. There's lots of barriers regarding fatigue, neuromuscular fatigue, heat sensitivity, etc. But a major barrier is this perceived negative experience of symptom exacerbation from exercise, and I'm going to cover that in the next slide or so to really go through that in detail. Unfortunately, there's also real inconsistency in the information being provided by both still existing healthcare professionals, but definitely what's out there on the web and obviously on the chats and things. And that's you know, a real difficulty that we've got as professionals coming against. And there's a really interesting paper which was only just released in July this year by Sagnia Bahini et al., that they were reviewing internet resources. And I'm going to talk a little bit about an activity, physical activity guideline by Caleb in 2020 that was delivered. So they were comparing it against that and the the more previous exercise guidelines specific in MS, which was the Latimer Chung that worked back in 2013. So what they did from these exercise guidelines in MS is to come up with 18 points of what you know, what websites should, you know, be talking about MS regarding exercise. And from all these websites, 27 websites that met their criteria, only 5 of the consistent messages about MS and exercise was actually covered. So we know that that inconsistency is really strong. And then unfortunately, what still really exists is a really poor referral rate, you know, and this has been acknowledged throughout quite a lot of countries as well, is this, that there's a poor referral rate, but also unfortunately, many people with MS really lack that knowledge and understanding of the perceived benefits of exercise. And this has resulted in one of the highest unmet needs of people with MS is accurate information regarding exercise. And Richardson, 2019, published a really interesting research paper last year about neurologists' view and understanding of exercise promotion. And pretty much what that came up with is that neurologists are in the key position to be obviously encouraging exercise and obviously doing referrals, but also highlighted that they are undertrained and under-resourced in the promotion of exercise. So again, that really falls on us as you know, that multidisciplinary team and the physios, etc., here about what can we do to collaborate in that multidisciplinary team and with the neurologists to really make sure that those referral rates are increased. So this is a really, really important part about treating MS, and I think it is the part that is not very well taught at that newly diagnosed state, and that's why we don't have that level of activity early on. It's this exercise-induced symptom exacerbation, which is unique to MS. So what we have, it's this heat response. When someone with MS starts exercising, obviously their core temperature raises, and they only need an increase of 0.5 degrees centigrade for that nerve conduction speed to slow down. So what that means is that they then start getting this change in sensory symptoms. So it's often like double vision, you know, blurry vision, change in sensory sensations like pins and needles, numbness, but also weakness, as well as this neuromuscular fatigue. So you can imagine that, you know, you've been diagnosed with a chronic neurological condition, and then you go and exercise and you suddenly feel a hell of a lot worse, and the room starts spinning and everything goes blurry and your right side goes numb. you're gonna lose some confidence pretty quick with exercise. So a lot of education is really needed at this point to really establish that this is a short-term exacerbation. Generally, symptoms can last anywhere between 30 minutes to 2 hours. And 2 hours is a really good rule of thumb, that if you've got individuals with MS coming back to you who had symptoms that lasted a lot longer than 2 hours, then you just need to kind of, you know, again, go back and review what you did in that last session. Was it a little bit above what that individual's exercise tolerance was at the time? Was there not quite enough anti-heating measures in? And what necessarily could you do to support that? So it is really important to really discuss this, make sure that you get any of those fears or concerns out from the individual so that they can really understand that it is temporary and that this is not a symptom relapse, because this is what individuals think it is. They go and exercise and then they get these symptoms and then they're convinced that exercise is causing them a symptom relapse. So the most productive thing that you can do, or proactive thing, is about that pre-calling. Now, unfortunately, none of us have the glorious amount of time, as the best proven research evidence in this is to sit in an ice bath for 20 minutes before exercising. Now, one, that makes it very hard for your clients to come to your clinic, or if they're at home, sit in an ice bath for 20 minutes before you start your rehab with them. But, you know, just most people, it just is not conducive time. So the next best evidence-based thing they found is actually consuming icy cold slushy. So what I recommend to my clients is get a bunch of ice cubes in a blender, blend it up, and then pour that into one of those thermos bottles. You know, we've got all those kind of steel water bottles now, which are amazing at keeping things icy cold, and that they're to sit on that before their session, during their session, and after. You can also get inventive with ice vests, you know, lots of air conditioning in your clinic and bits and pieces as well. But it's really that education about someone understanding that this exercise-induced symptom exacerbation, it does happen with MS and it's not to be scared of. The other phenomenon in MS is this neuromuscular fatigue, which is a little bit different to other neurological conditions. And I think, you know, this is something that, you know, we really need to take on with MS. That, you know, I've obviously been qualified and working for long enough that I remember when I graduated that we used to treat MS and Parkinson's under the same umbrella because they were just put together as that degenerative neurological condition. And obviously anyone here who's in the Parkinson's world knows that about 10 years ago, the treatment of Parkinson's has radically changed to the large amplitude, the power base, the dual tasking. And that's, you know, the way we treat Parkinson's now is absolutely radically different. And now's really the time for us to step up and realize that treating MS has all its own idiosyncrasies of how we really need to get that to be best practice as well. So neuromuscular fatigue, so it's direct fatigue of the muscle, and it's the energy stores that become depleted. And it's, you know, it's, imagine if you've got, you know, circumference of a muscle, you know, cross-sectional, and you cut a muscle in half. That, as we know as our anatomy, that a muscle's made up of lots of muscle bundles. Now, when something's partially innervated, it means that a bunch of those bundles aren't innervated. So when I go to walk, I don't use the whole, you know, muscle itself, the tibialis anterior, to pull up my foot, because I'm only walking. I'll only use a couple of bundles, and when those bundles get depleted, I've got plenty other bundles that are innervated for me to move to, so I can keep walking and keep going through my muscle bundles, and by the time I get back to the first few bundles, they've had the ability to get replenished and go again. Now, unfortunately, that is what doesn't happen in MS. Okay, so it's a temporary issue. Once they stop and sit down and have a rest, then they're good again. So really classic here is your foot drop, that someone says, you know, I'm really good for the first 10 minutes, and then my foot starts scuffing the ground and it's a nightmare. But I find if I sit down and rest for a while, then I can go again for 10 minutes. So the really interesting thing about neuromuscular fatigue is you're not going to cause any damage by pushing someone through it. And again, this is important to educate the individual with MS about, is that they're not going to cause any pathological damage with their MS by pushing through neuromuscular fatigue. However, for us, it's not really what we want to encourage, because again, if we take that foot drop example, that if someone's, you know, challenging, you know, if that foot drop, they're going to compensate and start hitching their hip. Okay, and then what we know is that through that biomechanical changes, they just learn compensatory patterns, which actually become a bigger challenge for us to treat further down the line. And also, if we're trying to push someone through walking with foot drop, the increased risk of injury, tripping, falling, losing confidence, etc., hurting themselves is huge. So, you know, a lot of education around, you know, why does muscular fatigue happen, and that it's okay to push it, but just be really aware that they're not going to compensate, and, you know, they're not going to cause themselves risk of injury. And the best way to manage neuromuscular fatigue is actually in interval training. And I'm going to talk a little bit more about how interval training works in a few slides' time. So benefits of exercise. So this is the bit that I'm going to kind of go through relatively quickly with you guys, because you're probably all over this, that we know that exercise can help cardiovascular health, you know, lung cardiovascular. We've got mental health, you know, reducing depression, anxiety. We've got strength, we've got bone density, we've got metabolic rate and weight management, we've got balance, we've got walking, quality of life, and function. So these are all areas that have got lots and lots of research established behind them. If anyone wants to kind of read some of that latest research in the general benefits of exercise and MS, I'll point you towards the Robert Mottle et al. 2017 paper, because that's the most up-to-date systematic meta-analysis review that they've done on a lot of the exercise research out there. So that's a great paper to work towards. Also, hopefully bits that you also know is that exercise has been well proven now in the MS world to show that it can improve fatigue, okay, and it can also improve neuropathic pain. And the reason I highlight these separately on the slide here is because fatigue and pain are again some of those biggest barriers to exercise for MS. So again, a lot of education needs to go in this, because you imagine when you feel deathly tired, is that thinking about exercise and doing exercise is one of the last things you want to do. So for individuals with MS to really understand that a lot of their fatigue is perceived cognitive fatigue, and though the human body feels exhausted, it's actually the brain that's tired. And if they get that body moving, often that can really help them feel a lot better. So some more of the actual more juicier benefits about exercise, of where the research is now kind of moving into, is this really exciting area of, is exercise actually potential disease modifying? So we know that when we're exercising people at that moderate to vigorous state now, with that release of BDNF, you know, are we starting to have effects on axon dieback or remyelination? So this is a really exciting area in MS, where clinically, you know, it's kind of been thought about because we've seen it in the normal population and some other neurological populations, and we're just starting to get some really good research papers through about it now, which is great. However, before we get too excited to jump on this bandwagon, we just need a little bit of caution that one of the recent systematic reviews by Sandroff et al. In 2020 did kind of look at the exercise training as a neuroplasticity inducing behavior, and they concluded that there is mixed evidence at the moment, and there's not quite sufficient evidence to examine the hypothesized mechanisms of action. So we're heading in the right direction. The problem is it's quite hard to test on the human population exactly, you know, remyelination levels and that disease burden. But the results that we've had in so far is an aggression 2019. They did a lovely systematic review, and they looked at the evidence that MRI studies confirmed that exercise training can improve central nervous system integrity and function, and that there is evidence of a positive effect of exercise training on the modulation of the blood-brain barrier, permeability markers, and brain-derived neurotrophic factors. Now, the blood-brain barrier is one of those areas that has been obviously really talked about with MS and that weakening of that area. So if we can get that stronger, that's really key. OSCORE in 2020, they did a single blinded randomized controlled trial of 34 individuals with relapsing remitting MS, and they did 8 weeks of 3 times a week of aerobic and Pilates exercise. But what they were testing was a significant improvement in long-term verbal memory, visuospatial memory, verbal fluency, information processing speed, and as well as functional speed of walking and quality of life. So what it was really just showing there is that, you know, we really now know that exercise is quite systemic with its effect, that we're now able to actually improve people's memory and cognitive function through exercise. It's been well shown now that exercise can increase the hippocampal volume and brain plastic response and decrease the rate of symptom relapses. I'd say there's a bit more about thalamic volumes here, which has been increased. And, you know, we've even got Negression 2021 was sort of saying now that there's a hypothesis that physical activity, particularly moderate to vigorous exercise, may serve as a disease-modifying treatment by improving brain health. Okay, we know that strength training can also improve neural drive, and increased neural drive means that it's increased energy efficiency of muscle contraction and also mitochondria health. But just as another really one out there regarding exercise, I found this when doing a little bit of update on my literature the other day, that I can't always pronounce some of these words, names quite well, is Kartaziad et al. 2021, they demonstrated that after 6 months of following a home program 5 times a week, that they actually had a significant improvement in gut bacteria in MS. You know, and obviously gut health and gut bacteria is a very buzz area at the moment, and we know that diet is very influential on MS. So, so when your clients are wondering, you know, what are the benefits of exercise? This is another great little draw card you can bring out, is that regular exercise also improves that gut health. Okay, so that is important. So I think it's really important to, again, when working with individuals with MS, a lot about that education we talked about to start with, about exercise, symptom exacerbations, about neuromuscular fatigue, but also to really inspire someone with MS that when they're exercising, it's not just good for their heart and their lungs and keeping their muscles strong. It's really trying to educate them that they've got the potential every time they exercise to maybe have a pathophysiological effect and actually change their MS trajectory. And that is a really powerful thing that you can give someone. So, you know, when we're looking at that, you know, compliance with exercise and stuff, it's, you know, it's our role to really educate this exciting research out there that they've got the ability every time they get slightly out of breath or lift some heavier weights or do anything to actually try and change that long-term trajectory. And what we've also always got to remember, and, you know, the way that when I get questioned by clients about, you know, well, how reliable is this evidence? And obviously, you know, we have to also be constructive about this, but also when we look at relapsing and remitting, which is 80% of the population with MS, is when they remit, they've had some form of remyelination. So we know in the early stages and those new stages about MS that remyelination does happen. But the real key about remyelination is activity dependent. So if someone's not being active and someone, especially after relapses, isn't driving those, you know, all those things we need from a neuroplastic point of view, high repetitions, variance, salience, enriched environments, and variability, all of that, then are we doing our best to actually really drive it from a neurological perspective? McDonald in 2012, they did highlight that the myelination fails during that later stage of multiple sclerosis, and they reckon this is either due to a depletion of the adult oligodendrocytes, propagators, or just from damage to the axons that they've got so far damaged that they just can't really remyelinate from there. So this is what's really then pushing us really towards that newly diagnosed. If we can get that newly diagnosed, minimally impaired, as active as possible, then again, every time they're exercising, they're potentially helping really to drive those remyelination factors within their own body. So bringing on to your latest exercise guidelines, I put this one as the main slide. So if you've got your handouts there, put a big circle around this, because if you want to know what is the latest and greatest of how to be exercising regarding MS activity guidelines, this is the latest paper, so Caleb 2020. And it's a really nice, actually quite short paper and easy to understand. So it's a great one to be disseminating around the multidisciplinary team. So what they really pull together in their recommendations is that healthcare providers should endorse and promote the benefit, safety of exercise and lifestyle activity. So that's all healthcare providers. So we need to get the GPs on board, the nurses, everyone that sees someone with MS needs to be checking in about their activity levels. They also state that early intervention and evaluation is really key, and ideally from someone who is an expert within MS, so a physio, OT, sports science expert. They also talk about 150 minutes a week of exercise or 150 minutes a week of lifestyle physical activity. So we're now looking at moving MS up to about 300 minutes a week of physical activity, which is very different to where it was. They talk a lot about progressing people gradually, that targets should be gradual based on someone's abilities, preferences and safety, and that as someone becomes more affected by the disease and their physical mobility is limited, exercise should be facilitated by a trained assistance. Really just acknowledging that more affected population do actually physically need help to exercise and move. It's not a case that they can often go and do it by themselves. So what's really nice about this paper, and why I encourage you to all have a look, is they actually break down these key exercise messages into the EDSS program. So we've got here 0 to 4.5, what the key messages are there. And then they also have then 7 all the way up to 9, but they do the 7 to 7.5, and they break down that more affected population in some really good categories of what are the key things that could be done. So as I say, you guys can go and hunt this paper out. It is freely available. It's a free online paper, so do head there. Now, obviously, I'm going to bring, this is what their recommendations were for the 0 to 4.5. It's a very busy slide. I don't expect you to read that because I'm going to get you to read the summary I put together. So if we just take a breath and have a look at this slide. So this is what the key recommendations are for someone living with MS regarding exercise and physical activity. So we got 3 times a week at aerobic, 40 to 60%. We then have up to 5 times a week of advanced aerobic where they're getting to 70 to 80%. So the aerobic, I would consider that as your physical activity. That is walking around the supermarket, that might be doing the housework, that's, you know, getting the heart rate up, but nothing overly strenuous. Then we've got our actually planned exercise, which is our advanced aerobic. Then we've got our high intensity interval training. So this is one of the first MS research guidelines that's actually brought high intensity interval training in. So they say that's once a week, and that 1 a week can replace one of the advanced aerobic sessions. You'll see that they keep their sets pretty short, so anywhere between 30 to 90 seconds. And again, they've only got 5 sets, but that's really right up at 90 to 100% predicted heart rate max, which, as most of you guys know, being therapists and working with individuals, it's very difficult to get someone quite up that high, but it's just showing you how hard the evidence is now showing we can work individuals with MS. Really important is this strength training 2 to 3 times a week. It is often the bit that gets missed. A lot of people will push the aerobic, but forget about the strength regarding individuals with MS. Flexibility should be something daily, certain stretches. I'm going to go for a couple of the key stretches that I recommend in a moment. And the neuromotor, this is where they're looking at balance training, fine hand function, cognitive training. So this is maybe looking more at that kind of gait training, gait specific stuff that we would do in more a hands-on therapy session regarding physio or OT. So it's a lot, and I don't know about you, but quite a few of you would go, wow, that's a lot for someone even without MS to be doing, okay? And what's really important about this is they do also say this is the minimum exercise and lifestyle activity targets for people with MS. So it's where the target is, and the targets are then above this. The big point is everyone's going to start at a very different level, okay? So everyone with MS isn't going to start bang on this. You may have people who are so deconditioned that you're working on just getting their aerobic to 10 minutes 3 times a week, and then you're going to progress something in from there. So, you know, my response to, oh my God, this looks like a lot of exercise, is that if you've been diagnosed with a degenerative neurological condition and you now know exactly what the evidence shows is needed to have this potential brain health, you know, remyelinating neuroplastic effect that could be there, then you've got a real ability to influence that lifelong journey. So as I say, it's a really good paper. It is pretty short, so I would recommend looking at it, and it just pulls together some of the those recommendations really, really well. So to touch on high intensity interval training, so this is new in MS. We used to definitely treat MS wrapped in cotton wool. You know, don't work them too hard, don't let them get too hot, okay? That's all changed. We can work them really hard. So, you know, high intensity interval training, anywhere between that 70 to 100% of predicted heart rate max. You know, I even go down to 10-second intervals to start with individuals, and the ratio needs to be at least a 1-to-1 rest ratio, I found in clinical practice, and I'll show a little bit more about an interval table in the next slide. So example is, if you've done 30 seconds of exercise, you must do it 30 seconds of rest. Now again, this is individual depending on someone's heat and their neuromuscular fatigue, that they may need that rest ratio more. But the high intensity interval training, you know, it's really good because it allows you to work someone really hard to get the benefits, but because it's interval, you get the ability to reduce the heating effect. So it has been shown that in interval training can be less heating than endurance training, and also it's the best way to manage the neuromuscular fatigue. So people are less likely to walk out of your session with a big symptom exacerbation. And we've got some really good research, you know, coming out in this area now, that it's shown that HIIT training is significantly higher in oscillating patterns of physiology and perceived exertion compared to continuous training. So they're looking at a 10 to 40% better outcomes when you do HIIT training compared to continuous. We've had recent publication, Langascoffey and Christian at et al. 2021, who showed that high intensity aerobic training resulted in lower relapse rates. So we are starting having a disease modifying effect if we can do that. Kapatkin's work in 2016 and 2015 is some really interesting stuff around strength training in intervals and walking distances. So, you know, that's some papers worth looking at. And again, another recent paper by Justin 2021, who did a randomized controlled trial of just 3 weeks of high intensity interval training work compared to moderate training, that they showed it was only the HIIT training group that lowered their neutrophil to lymphocyte ratio, and that neutrophil to lymphocyte ratio is associated with disability status, symptomology, and disease activity. So again, that's a really interesting, that we know there's benefits of general cardio continuous training, but if you can get some high intensity in there, it's potentially going to give them an extra little push. So this is the table. This is what we use in MS Get a Head Start. So MS Get a Head Start is a 6-week program to take someone from no to go, so someone who has not been exercising at all. So we start our intervals at only 10 seconds, and this is done as a circuit-based exercises of 9 exercises. So do 10 seconds on, 10 seconds off 3 times, and then you'll see as we go through the weeks, the interval time increases. We keep it at 9 exercises of varying training approach, so from cardio to strength to balance to flexibility, so they get to do all of it in that 9. Now you may have individuals that never get above 20, you may have individuals that never get above 30, and that's fine. You just go to where someone's, you know, ability is to work. So again, I'm just going to push that the best way to control someone's heat sensitivity and their neuromuscular fatigue is intervals. So it doesn't all have to be high intensity intervals. You can even be working on continuous walking by doing, let's say, 2 minutes of walking, stop, have a rest, okay, compared to, you know, trying to walk for 10 minutes and know that you're going to get into that neuromuscular fatigue issue. All right, so that was the wrap up about all the evidence and the exercise part. Now we're going to get into a bit more of that clinical stuff. So key MS assessment points for your subjective. Now, obviously, you guys are all qualified professionals, so I'm just going to pick out a few things that I would be thinking about when I'm treating someone with MS that are different to obviously if I've got a Parkinson's or stroke client, okay? So number 1 is, what is their current physical activity you know, both exercise and physical activity, and do they know the difference between the two? Obviously, the fatigability issued, heat sensitivity. Now, this can be hot and cold, okay? But also, have they noticed any unusual symptom production with exercise? Have they had any of this exercise-induced symptom exacerbation where they know that they get double vision or they know that their right side goes numb? I always ask about exercise intensity. My question is, do you currently get out of breath when you exercise? 99% of people say no, so that's where we know we need our biggest amount of change. You know, when people say their walking is affected, I always ask about walking limitations. So how far can they walk before their walking starts to change or they have to stop? And obviously, we know with MS, we've got to really establish those concerns, barriers, but again, they're goals, because like anything, if it's not salient, then we're not going to achieve those best outcomes. And again, objective, you're going to do all your normal neurological objective testing. What is worth doing is obviously some sensory testing, because sensory distribution can be quite mismatched throughout the body due to those different areas of that demyelination effect. Spasticity is really key to test, especially in their plantar flexors, and I also find in their hamstrings. So make sure you definitely get in there and check that spasticity. I'm going to come to ankle range of movement, in particular with the foot drop, but obviously we've got our range of movement, gait patterns, reach patterns, because we're looking for compensations, manual muscle testing. But when I do the manual muscle testing, I'm also looking for fatigability. So if I've got someone doing dorsiflexion, and then I'm going to put some downward pressure onto C to see where they are on that, you know, out of 5, are they a 5 out of 5 or a 4 out of 5? I'm also going to hang there for a while. So I'm going to put downward pressure on those dorsiflexors for about 10 seconds to see if we get a fatigability. And that's often where they might start great initially, but as we get towards 10 seconds, you can start feeling that one side has got a lot more neuromuscular fatigue going on. With this population, obviously, we know that optic neuritis is one of the first signs. If someone has optic neuritis, they often go and get them checked for potential MS. So we know there's a huge amount of vestibular involvement in this population as well. So if vestibula's your bag, good to test this. I'm not a big vestibular therapist myself, so I do enough to do some screening, and then I've got a great colleague that I tend to send them off to work particularly on that. And I think that objective is really looking at where their self-efficacy and their anxiety is, because they won't necessarily report it in their subjective, but as you start getting them to move around and do some of that objective testing, you might pick up some of those things a little bit more. So some key MS outcome measures, again, the practical ones, you know, I'm going to presume you guys are all over 10 meter walk tests, mini best tests, high mat, grip dynamometers. I really like a grip dynamometer in MS, you know, just because we know that grip strength is really good at showing us some overall upper body strength. But I'll just highlight these self-assessment measures. There is a population I do a lot of self-assessment measures in. So obviously the MS 12-point walking scale, your fatigue severity, like self-efficacy for managing chronic disease, and anything around quality of life with MS is really interesting, because we might not necessarily see a huge change in physical function regarding testing, but if we can change someone's perception of how well they're doing and what their quality of life is, then we know that we're doing obviously really well from a therapy point of view. Exercise testing, now I put this in because this was obviously in the brief that I got asked to talk about, is, you know, what do we do for exercise testing? You know, is it looking at endurance? Are you going to do a 6-minute walk test? You know, is it looking a little bit more on speed and strength, like a step test, or, you know, a 30-second sit to stand? But, you know, with this population on exercise testing, you've just got to be really careful about what are you actually testing? Are you testing fitness, or are you testing fatigability? Okay, and obviously that's a really grey area, you know, and, you know, heart rate zones, recovery, you know, how much recovery do you need to give someone before you do another test? Taking heart rate, if we're doing a cardiovascular test, is difficult because they do have quite a lot of autonomic dysregulation going on. So heart rate is not necessarily always the most reliable measure when it comes to MS either. I'm now going to take you on to foot drop. So my first thing about foot drop, is it foot drop or is it actually decreased ground clearance? It is very rare that when you have someone with MS that they have a flaccid foot as a foot drop. So I'd much rather talk about this as decreased ground clearance, okay, rather than foot drop. It's due to neuromuscular fatigue, okay, because it often kicks in after someone started walking in the early stages. Obviously, when someone has progressed with their MS down that trajectory, that foot drop's probably more permanent. But in those early stages, when it's just starting to happen, they can often walk short periods, be fine, have a rest, and then go again. However, the biggest area that is often forgotten about foot drop, it's loss of ankle range. It's that plantar flexor tone and spasticity. If you've got to think about, if you've got, you know, your weak dorsiflexors here, but then you've got a tighter, spastic, high-toned plantar flexor that is getting tighter and tighter, and then your weaker muscle is struggling to move against this bit of concrete, then again, it's that decreased ground clearance. So I'll show you my favorite exercise for this in a few slides time. But pretty much I treat decreased ground clearance with a lot of work on plantar flexors, which is quite opposite to what often you think. Obviously, we need to look at what that dorsiflexion weakness is, but it's really amazing when you actually get them into a mid-range dorsiflexion, i.e. just holding 90 plantar grade, how well a lot of them can hold it, okay? So we know then it's more due to fatigability, but also through that plantar flexion strength. Everter weakness is massive, and there's a reason why I set up my TheraBand in a certain way to try and access a bit more everters. And really, where we get decreased ground clearance is a lot of this is actually coming from a loss of toe off, so it's a loss of push off. And then what happens is that they have to overuse their hip flexors because they don't have enough push-off power to be generating. So increased hip flexor often then means that they start circumducting, and then that foot looks like it's not clearing ground so easily. So, you know, if you really break down and do a really good gait analysis on an individual with MS, you'll really start to see that it is much more about decreased ground clearance rather than foot drop. So again, you've got these slides printed out, so I'm gonna talk more about the exercisey stuff rather than some of these testy stuff. But you know, that's subjective. Are they catching, tripping? Is it a floppy foot? Do they need to stop and rest? You know, as I say, objective range of movement. So I'll do plantar flexion length by doing the foot against the wall and trying to get the knee against the wall. Okay, so looking at actually soleus length is a really nice one to do. And obviously then taking that foot back to the 5 centimeter or the 10 centimeter line. And obviously doing all of our muscle strength testing there. Outcome measures. So 10-meter walk test, obviously, you've got to ask its value in foot drop if they don't have foot drop until they've been walking for 10 minutes. So is something like the 6-minute walk test better? Or are you best to chuck them on the treadmill and make them walk fast for a few minutes and then have another look at their 10-meter walk test? Okay, because it's quite often, especially in that newly diagnosed, minimally impaired population, they'll tell you they've got foot drop, but you know, you've been chatting for 20 minutes in the subjective and they walk up and down for their 10-meter walk test and you see nothing. Okay, so you do need to get them to that fatigable state to see. And the 12-point MS walking scale is a really good self-assessment because that will pick up if they've got that foot drop stuff. And walking distance and time prior to neuromuscular fatigue is, you know, is a really interesting one to see if you can measure that. So treatment ideas, this is the juicy part. So this is my #1 thing that pretty much anyone with MS comes into my clinic walks out with is a calf stretching board, okay, because you can do both gastrocs and soleus on here. You can do one foot, you can do both foot. Obviously, normally I get them holding on to something, so it's not a balance test. The reason I really like a calf stretching board is that you know that the feet are nice and protected. You know, if we try and teach the lunge stretch or the hanging the foot off the step, I always get really worried about overstretching, you know, all those lovely, you know, internal muscles in the feet. So I'm a great fan of a calf stretch board. And as I say, there's not many individuals with MS who I've met who I haven't chucked on the board and they've gone, oh my God, I'm tight. We've stretched them for about 3 or 4 minutes. So we're looking at prolonged stretch here, and then they get off and they feel that they can walk so much easier because we've just got a little bit of that quick kind of stretch response, you know, letting go in those tight plantar flexors. The other one that's really key, because a lot of people trip over their toe, not their foot, okay, is stretching that long flexor. And again, if you get some individuals with MS to sit down and sit on those toes and do that toe extension stretch, a lot of them won't stay there for very long at all because it'll be that tight. So that's another real key idea there. Now, normally I do this one with a golf ball because it'll golf with one of those nice little spiky massage balls. Okay, a lot of individuals with MS have really hypersensitive feet. Okay, and that hypersensitiveness in their feet is causing lots of those tonal changes. So trying to release those feet is really, really good. TheraBand, this is a lovely way that I strengthen dorsiflexors and everters at the same time. So you wrap the TheraBand around the foot, pull it, and then stand on it with the other foot. So when you're coming up into dorsiflexion against the resistance, you're also resisting that pull in, so you can really work those everters as well. Wobble board, but actually sitting and doing some wobble board work is a really nice one of getting some ankle movement. Another everter here, where just sitting, squeezing those knees and medial malleoli together to really help activate those everters. Orthotics, you know, a lot of individuals have pretty messy up feet, and you know, if foundations are not right, then you know the rest of the system can fall apart. So getting some good foundations is key. FES is great for obviously everters and dorsiflexors. This is a great little rubber device if you've got lots of curling toes, okay, that I find them quite useful for foot treatment. And also use a lot of K-tape as well, do a lot of K-tape on dorsiflexors to help with that facilitation of them. Orthotics, could be very brief on orthotics. We've got dictus bands, I think they're called foot ups in Australia. Really good for fatigability because they can be in someone's pocket, okay. We've got obviously our very cheap AFOs designed in the 80s. They are only really good for that short term, and then really if someone's going to stay in an AFO, we should be going carbon so they get some form of ground reaction force. MS is a good population where these FES orthotics can work nicely with. My only thing about them is that they can be a little bit variable, so that is a bit of an issue. And you know, not many individuals with MS only have ground clearance issues, i.e. foot drop, and this obviously only works on dorsiflexors. It doesn't work on the rest of that ankle instability. If you've got someone who's pretty active, I do love a turbo med. Okay, I do find these really good because obviously much more comfortable fitting on the outside of a shoe. And if you've got someone who, again, is kind of getting fatigue at that 20-30 minutes, but they feel now that they can't go tramping, get them a turbo med and they're often charging away. Knee hyperextension, MS, tricky one. So my thing is it's never really coming from the knee, it's coming from the ankle or from the pelvis. Again, generally loss of range of movement of the plantar flexors, so it's that gastrocs inserting above the knee, pulling the tibia posterior of the ankle, and then to say it's that poor pelvis alignment going into anterior tilt, too much hip flexion to compensate for a lack of push off, and forward lean gait. You know, often there's quite a lot of proprioceptive sensory loss. People can't really feel where their feet are due to sensory loss, so a lot of people will actively lock their knees back to try and feel more secure. So it's very much a compensatory adaptive pattern as well, and obviously can be hugely influenced by a lot of spasticity and neuromuscular fatigue. So again, outcome measures very similar to what we've done before. Okay, so the only thing extra that I'd check probably on here is obviously knee pain is a good one, but obviously gait efficiency, photos, videos, really good. So treatment, the back on the calf stretching board, obviously lots of one leg standing with good knee control. Eccentric work of the plantar flexors, so doing step overs, so where you're keeping the foot on the step, so you're not allowing that heel to come off the step. So that's a really good one to try and work on that knee control. You know, anything around the glutes, bridging, walking bridging, obviously is fabulous. Lots of high knee work for knee hyperextension because it's a great way of engaging glutes and hamstrings, and you don't have to worry about that knee at that time. eccentric hamstrings, okay, and the hamstring curl, and in the running world, and you know, I don't know how transferable this is to MS, but I kind of agree with my running coach a little bit about it, that side planking, because essentially one side has to be stable to allow another side to move, which is very much about our gait. We need one side to be stable to allow a moving side. So side planking on knees, working up to full side planks, you know, really good. Again, do they need some dorsiflexion strength to help bring that tibia anterior? If the plantar flexors are really tight, I do wedge them quite a lot, because otherwise you're fighting a bit of a losing battle until you can get some more range in their plantar flexors. Again, lots of things like K-taping, and then I've got some rigid tape and the hyperextension taping here as well. So just using whatever you can to give a little bit more proprioceptive feedback. So typical MS upper limb weakness patterns, you know, they can have a lot of scapular instability. It's extensors, lots of wrist and finger extensor weakness. You know, again, just kind of some of that compensatory loss of glenohumeral rhythm. You know, ultimately things become difficult, and then they get a lot of learnt non-use in MS, so then they lose that grip strength and dexterity, and a lot of sensory loss can happen in the fingertips. And obviously if you've got that sensory loss, gripping things is unreliable. A lot of people drop a lot of things, so then it's a case of, again, that learnt non-use. So again, a really good subjective into these upper limb is really key. Upper limb outcome measures, as say, I'm a big lover of the grip dynamometer, a 9-hole peg, but you can box and blocks, action, research arm test if you've got access to that. And just for some like scapular and upper limb strength, I find like how well can they 4-point knee and control that arm? Can they load through that arm there? But even going into a high plank or an incline press up, how well can they keep that shoulder stability is a nice little test on there as well. So treatment ideas, obviously getting the wrist range of movement. So again, they tend to get a lot of flexor tightness there, so stretching that out. Again, I think 4-point kneeling is a nice one because you can access some core and shoulder girdle work. Big scapular retraction fans, so I really like prone as well, because secretly you're stretching out those hip flexors in that prone position as well. Lots of nice external rotation work, again, going for that posture. Wrist extension, you know, hand strengthener. When I do that hand grip test to make sure that they don't just strengthen those flexors, I get them to grip, and then they have to go for active extension and hold the grip test between the grip strengthener between their thumb and their index finger, so they're getting that active extension as well as the resistance against the grip. Elastic bands for some finger abduction. Again, FES does work really nicely in this population. Splinting, okay, as needed. Sensory, so that's a very little picture of some spiky balls and Velcro and different sensory things in there. Mirror box. Again, I've done a fair bit of constraint-induced movement therapy in MS and had some really good results. And things like the Sabo, not necessarily the Sabo Flex there, but the Sabo glove can be very nice with the MS population. So that is a well for all that, and now I'm going to go to some of the little fun parts, and I know that I'm got a few more minutes to go, and I'm already over by a couple of minutes, but just wanted to show you a couple of case studies. So this case study so this lady here, 39-year-old female, diagnosed not very long ago, working full-time, has a child. So she reported to me left leg weakness, walking limited to 20 minutes because of what she felt was foot drop, bladder urgency, some heat issues, and some sensory changes in her foot. She's not able to run because she was going to CrossFit, so she was pretty fit and active, but she found out she could, you know, wasn't being able to run with the CrossFit group, and now that her walking was limited, she was really actively actually avoiding walking. So her EDSS score was 2, which kind of puts her in that category of minimal disability of only one functional system, living well generally, but you know, wanting to understand and how to help with some of those hidden symptoms of MS. And her MS medication was Tecfidera. So you'll see a nice video of her gait in the moment, where she's got left foot, loss of heel strike, increased hip flexion on the left, and decreased stride length, and a loss of left push off, lack of arm swing, and holding up on the left upper limb due to an instability in her core and her pelvis. Left foot, increased tone and spasticity throughout her plantar flexor and significantly in her hamstring. Okay, foot very hypersensitive. I do a lot of one leg calf raising for strength test. So you can see she had a huge difference between her right and her left side. But her actual walking measures there pretty much in normal gait ranges for her age. So that's that whole minimally impaired that, you know, we didn't necessarily pick anything up on there. So I'm just going to ask Nick to play the video for me. The left side?
Yeah.
All right, so the client presents here with a significant left side hypertonicity, which is very sensitive and creates a locked motion in her left lower limb, gait compensations, and demonstrates a lack of push off and a stiff left ankle due to muscle co-contraction. The client also has a significant power and speed in the left compared to, which makes it quite unbalanced. So she walks down the street. She doesn't look too bad, but there's things going on. All right, so treatment, hopefully that's what you guys can see now, is, so first of all started with education provided on like that symptom response and MS exercise and principles of exercise. So she did a lot of plantarflexion, strengthening and lengthening. She was really tight on that left side. Did a bunch of that foot mobilization. All right, sorry team, there's a bit of moving between the screens. My screen keeps kicking me out, so apologies about that. So plantarflexion, strengthening and lengthening, got her doing a lot of that foot golf ball mobilization, and also sent her off to some massage through that left side of her hamstring and plantarflexion and a roller. Lots of core stability. She was incredibly weak in her core. Quite a lot of proprioceptive work. We did cross trainer and bike sprints. We did treadmill sprints and backwards walking, and I'll show you some examples of that. We did do some left leg anti-hyperextension tape with the ELAB, and she found that she could actually walk faster once that was applied, which was interesting just to get her in a better alignment. Now, interestingly, we tried a Victus band with her, and it didn't work. And the reason it didn't work was because her dorsiflexors were not her primary impairment. Her impairment was actually the plantar flexor spasticity and tone. So it just kind of gives you a good idea of why trialing stuff at sometimes is being really aware that it probably might not work. And then we got to the point of doing quite a lot of running drills on the trampet, ballistic training, skipping, you know, bunny hops. Vibration platform was really good, and again about helping to decrease some of that spasticity. And you'll see some prone lying facilitation work, the hamstring curls. So Nick, I'll just get you to play that second video for us. So this is obviously her strong side, her right side. We're just doing some hamstring curls at speed, and then this is her left side, and you can see that tonal change that's kicking in. So we just kept them very short, just five rep of 5, and then we've got her doing some backwards walking on here, and you can see that obviously that backwards trying to break some of that tonal pattern was really challenging for her, but she went a huge way in I'm still working with her now, but in that kind of 6 months, and I'll show you her home programs in a second, did really well. So this is, again, you guys have got copies of these slides, so you can look at this in a little bit more detail afterwards, but this is what she originally went home with. So you can see that I gave her the calf stretching work, she got the big toe extension work, the TheraBand for dorsiflexion, the real plantar fascia release and some foam rolling, and just a lot of focus on calf strength. So we looked at length and strength, okay, and then 4 months later, obviously I saw her in between some of this, but just to give you guys an idea of where her program was 4 months later, is I love this core exercise of someone lying lengthways on the foam roller, and that they're having just to do little lifts of their foot off. Really good way to see that core instability by just putting them on that roller. She really struggled with that, you know, modified side plank, tricky, started to be able to do some more proprioceptive one leg work. But then you'll see as we go down that list, we had jumping, bounding, skipping, really trying to work on some explosive work and stationary bike. And after this program, I got her to run up and down the corridor, and she burst into tears because she hadn't run so well in about a year. So just showing that that ability to keep progressing someone is there. All right, moving on, case study 2, the moderate impairment. So this is our EDSS 7. So 37-year-old female, diagnosed 23 years ago. So someone who's obviously had this disease for a much longer time, which the reason that it's important to highlight this because 23 years ago we did not have the disease modifying therapies that we have available now. Okay, so I do believe that, you know, the MS population we're going to be working with as we continue into the future is going to change again. So she's still doing some part-time work. So she pretty much had no left-hand function and had been like that for many years, but she was starting to get right-hand weakness and coordination loss. So that's why she'd come to see me, is she'd given up on her left hand ages ago, but it was now that her one dominant hand was starting to go weak, she knew she needed something. She could walk a few meters with a frame, and she did have a bias FES orthotic on her left leg, and she was also aware that her balance was quite poor, and she was going to another therapist for some balance classes, and she was not on any medication. Now, an EDSS 7, I'm just going to highlight here, is actually a bit of an interesting level to treat, because I would say the majority of people I treat are either at about 6 or 6.5, i.e. they can walk over 5 meters but not up to 100, or they're past 7. They're at the point where they're essentially wheelchair bound and need assistance to transfer. So someone who's in that 7 is kind of right in that phase of really just down to only about 5 meters, but can still transfer by themselves, which is, you know, they don't often tend to stay at 7 for very long, unfortunately. So on assessment of a lovely case study 2, so she had that very protracted shoulder girdle, you know, so that whole kind of, you know, shoulder alignment was very poor, very kyphosed posture in standing because she was sitting so much. Obviously reduced range of movement. She had no dexterity in her left hand and weak in her right. So we did the box and blocks with her at that time, and you can see obviously there's big difference between left and right. Fatigue severity score, not bad for someone with MS, 30 out of 63. And she was independent with her sit to stands, but really poor technique, you know, that real kind of overcompensating for her right upper limb and locking the legs back. So her treatment, so again, even with that, you know, EDSS of 7, so education on exercise and neuroprotection. So we worked out for her that we could get her on a recumbent bike and getting her doing some sprints on the recumbent bike, trying to increase her time spent in standing, and a lot of sit to stand works. You know, did quite a bit of prone standing with her from a treatment point of view to just try and help with that posture. And I'll skip a couple of points down, but also abdo binder. So I do use abdo binders just to help with some of that postural work when they just need a little bit more support, especially in functional sitting. Upper limb strengthening, we did a lot of high sets, low reps. So it might be a set of 5 sets, but only 5 reps. And we did a lot of FES on her extensors and flexors, but also off to the OT for a whole wheelchair seating assessment, because it was her sitting posture and being so kyphosed and sitting, which was really limiting that ability to reach. And another one that I do work with, you know, this population as they're getting more wheelchair bound, is the power breathe, your incentive spirometer work, to really see if we can help create that intercostal strength and some of that core strength that they can't necessarily, you know, get out and do bridging and stuff by themselves so easily. And I do find that, you know, things like the incentive spirometer are really good for that. So her home program, slightly different in the sense that I set her up an upper limb program and a lower limb program. So, you know, she had some obviously range of movement with the shoulder flexion, grip strength, some finger extension specifically, some tricep work. She had her own FES, so we, you know, played around with that. But you'll see with, again, it's the sets and reps. It's only 5 sets and 5 reps. and her dorsiflexion stretch was obviously different because she's obviously in a wheelchair and she wasn't safe to be getting up on the stretch board. So she just, you know, made an effort about sitting on the edge of her wheelchair, sliding that foot right back behind her to get that dorsiflexion stretch. And she had a carer that was coming in to see her that could do some of the sit to stand, plantar flexion, and some of that bridging work with her. So that is a whirlwind of MS and exercises. So there's always a hell of a lot to cover. So I think the main take-home points that hopefully you've grasped from here is high intensity interval training is safe in MS and it is really effective. And if you want to get some fast gains, you know, really go for it. Really important that you manage that neuromuscular fatigue, and that's where I really encourage interval training for both your strength and your cardio. But please, please, please do make sure you really educate and touch base with your patients really regularly about their knowledge about exercise-induced symptom production and how they're coping with that. And for feet and knees, always test those plantar flexors to see if you can get that length in that feet and knees, and early intervention is a must. And thank you ever so much. And I'll hand this back to Nick, and she's going to do the questions. So if anyone wants to contact me or know anything more about MS, get a head start, then please visit there. And on your handout, you'll see there's about 4 pages of all the references as well. So hopefully that will give you some light entertainment as well.
Gilly, thank you so much. You have given us 20 years of your expertise succinctly in an hour and a bit. So thanks, Gilly. Lots and lots of fantastic information. Our attendees have stayed online. They've been really interested. I'm going to ask just 2 questions, and other questions we will get a reply to you offline. I have to ask Tanya's question because she got on very early to squeeze her question in. So Tanya asked, I'm treating a secondary progressive client who experiences adductor pattern tone with movement or touch. What treatment strategies would you recommend in treatment sessions?
Yeah, that's great question, and could be quite a long answer. It's always very difficult to answer questions when you haven't necessarily seen the presentation. But when it comes to something like adductor tone, you know, if you think about those adductors grabbing on, and they're often grabbing on because of instability elsewhere. So that would be the first thing that I'd be saying, like, you know, where is that instability? You know, probably higher up around her pelvis and around her core, okay, and also around the ankles. Like, you know, if her ankles are quite weak and she's got too much anterior tibial movement, are those adductors then kind of gripping on to stop her knees going even further? So often that adductor tone is it's a hanging on against gravity, so she's got a lack of anti-gravity muscles actually working. So first of all, look at that strengthening. If she's got adductor tone, she's probably also got a significant amount of tone somewhere else as well. So when it comes to kind of desensitizing, you know, there's lots of things to try. I have found that individuals with MS do respond really well to vibration platforms, especially that they can sit in their wheelchair and just put their feet on it. So we've got a vibration platform in our waiting room. So a lot of our spinals or MS clients will come and put their feet on it and, you know, wobble away for, you know, trying to desensitize some of that work. It's definitely a wheelchair and positioning one as well, or how they're sitting and how much those legs are grabbing in. You know, you can do some TENS work or some FES at that very low level, just that sensory along the adductors to see if you can help switch them off. I'm also a big one about still getting my hands on as a physio and getting in there and doing some myofascial release through the adductors. Obviously, not many people would like that, but, you know, you might be able to get in there. But also, you know, MS do really respond well to Botox as well. I don't like baclofen in MS because it tends to take them off their legs. Obviously, I'm not the neurologist, so if the neurologist reckons it's the best thing, then obviously we'd do it, but we'll always keep a really tight eye on their function. But I do find MS do respond really well to Botox. So that would be, you know, once you've explored a lot of things and it's not working, you know, maybe have a look down there. Other one could be things like compression shorts. just thinking off the top of my head, like again, a lot of tonal things can desensitize when they've got that nice compression. So maybe some skins, you know, some tight compression shorts might be worth trying as well.
Fantastic, Gilly, thanks. And just one last question then from Lily. We have a few others, but I will email them offline. Lily's asked, what's your view of aquatic physio in a hydro pool? What time limits?
Amazing. I am a huge fan of hydrotherapy, and especially hydrotherapy for MS. Now, the tricky part is obviously the heat issue. So we have to be really clear here that at 34 degrees, which generally a hydro pool should never be anymore, that is thermoneutral to the body. Okay, so actually there isn't an overheating issue with individuals with MS at 34 or below. The issue where individuals with MS have going into a hydro pool is the ambient temperature. Okay, most of you might know this when if you've worked in hydro, or I know you're going along and watching kids swimming lessons inside or something that's sitting on the side of a pool, you know, is incredibly hot because of that ambient temperature. So if you're going to do hydro with MS, you by all means, I've got individuals with MS who exercise in a hydro pool that we use, which is at 34 degrees. Anything more than 34, then you're going to get a heating effect, but you've got to have the ambient temperature. So we open all the doors, all the windows about half an hour before the class comes. We've got big fans blasting to try and make it almost that the outside temperature, you know, out of the water is really cool. And again, lots of getting them, they must come and drink lots of ice cold water through their session, which is a tricky one because a lot of individuals with MS obviously have bladder issues, you know, urgency, frequency, and incontinence, and drinking water throughout their therapy session while in a pool makes them a little bit hesitant. So a lot of education, and they might obviously need a few quick accesses out, you know, to go to the bathroom. But the pool I find is an amazing place where you can get a lot of extra movement, a lot more power, a lot more intensity without having to worry about falls, neuromuscular fatigue, and all of that. You should still really work on intervals though, because the problem is if you work someone really hard in the pool and then they go leave and they're a wobbly mess, that's often what then puts them off the pool again, is that they weren't able to walk out of the pool. So again, whenever you start any form of exercise with someone with MS, keep the reps and sets and intervals really low. Make sure those first few sessions are really positive and that they leave knowing that they've completed it and they haven't had any adverse effects.
That's great, Gilly. Thank you, and thank you so much. So much information. I'm sure we'll reconvene another webinar. Okay, so just a reminder, Andrea touched on it, lots of support for your clients with MS from NDIS if you're in Australia, support coordination and allied health. We've got a helpline service that you can call with help for you as a health professional, or definitely lots of help for your clients. We've got social workers, we've got nurse advisors, we've got MS experts there, we've got employment support, respite, education, a wonderful peer support program if your client would do well to be matched with somebody else in similar situation who is living well with MS, and we have residential care. Lots of resources for you, some fantastic podcasts for your clients, newsletters, an online library that you can access as a health professional as well. So here are our contact details. The gateway to all of our services is through MS Connect, 1800 042 138. Thank you so much for your time tonight. Huge thank you to our presenters, Gilly and Andrea, and thank you for APA partnering with us to deliver this webinar tonight. Thanks, guys. Bye for now.